Hello, and thank you for coming to a presentation on the Anesthesia app, which is a mobile application that we designed for anesthesia education. We created this application to help undergraduate medical learners during their anesthesia rotations. So, anesthesia often has a steep learning curve, especially as medical learners are expected to understand the fundamentals of the discipline in just under 2 weeks. At the same time, smartphone and tablet use is growing increasingly prevalent as both an avenue for education as well as in clinical practice. So we thought that an anesthesia app would be a good way to reach medical students and help educate them during their anesthesia rotations. In order to develop this app, we initially reached out to medical students from across Canada and surveyed them to understand which features they would find most useful in an anesthesia rotation. Using this feedback, we started to develop a framework for the app and gathered information from various sources, including the UCSF Book Anesthesia Reference Guide, various drug monographs, the Stanford Anesthesia Emergency Manual, uh, local pre-anesthetic questionnaires used here in Hamilton and Niagara, as well as, of course, expert guidance from practicing anesthesiologists. We then use this feedback and this information to create an app in the Android Studio framework as a proof of concept. So, in the initial survey, we received feedback on the most desired features in an anesthetic app, including protocols for emergencies, drug dosage guidelines, as well as preoperative evaluation checklists. Other features that were requested include more pharmacological information on drugs, adverse event response options, as well as fluid calculations and other such anesthetic considerations. So, using this feedback, we initially developed a drug dosage list that contains most of the common drugs used in anesthesia. These drugs are calculated based on age and weight based dosage and will automatically adjust for pediatric versus adult populations. At the same time, these drugs also have options for different modalities of usage. For example, propofol induction versus continuous sedation with propofol will both have a listing for the recommended dosage guidelines. We plan to continue improving this feature using more pharmacological information on the drugs, as well as expanding the drug roster for even more drugs covered in anesthesia. At the same time, we developed an emergency protocol list that was adapted from the Stanford Anesthesia Emergency Manuals, which is very comprehensive for a lot of common anesthetic emergencies. And we hope to keep developing this protocols and integrating it more deeply into our app, including patient considerations and drug dosages going forward. Finally, we have developed a pre-anesthetic checklist that is based on the current checklist used here in Hamilton and Niagara Health. This was created in feedback with current practicing anesthesiologists as well. So this checklist will guide you to taking a preoperative history on many of the common comorbidities an anesthesia patient may present with, and it will also help you create a report that summarizes the findings of that anesthesia patient at the end, which can then be used for further anesthetic management and preoperative optimization. So we have developed this app and have started distributing it in a private alpha among medical students here at the Michael G. DeGroot School of Medicine. We hope to keep refining this app based on their feedback as well as previously requested features, and to integrate all the features of this app more tightly with each other. As we progress, we also hope to release this app to the public both in an Android and an iOS framework. That concludes my presentation on this poster for today. Thank you for joining us. Hello and welcome to our presentation, Sleeping on Diversity, an analysis of the race and gender composition of academic anesthesiology faculty in the United States. So just to give you a little bit of a background on the situation, the diversity of patients in the American healthcare system is ever increasing, with over 40% of the patients under the age of 64 being considered non-Caucasian. It's been well shown that diverse medical teams provide better care for a diverse population with better discussions, more cultural understandings, and improved problem solving in varied perspectives. And this is increasingly important in an academic setting as a diverse leadership team and academic team helps drive research towards understudied populations and attracts a more diverse academic roster into the staff as well. In addition to the racial gap that has been shown in medicine, there's also a gender gap. As you know, 50% of the patients that we see on average are female. However, in positions of academic anesthesiology, women have been shown to be less represented. And this has also been corroborated with the $13,000 per year wage gap between men and women. So this study aimed to analyze these disparities and try to understand where the gaps in equity and diversity were happening. This study used a retrospective cross-sectional analysis to study the diversity of academic anesthesiologists using dataset extracted from the AAMC annual report on faculty appointments. The study used methodology that was recently validated in manuscripts and analyzing diversity in the internal medicine and surgery workforces. And so we thought it would be a good fit for the anesthesiology workforce as well. The physicians in the study were classified based on their race and their gender, as well as their current academic position, their tenure track, and any degrees they might have held. The percentage of the total group was calculated per year and then averaged to provide a look at the general state of diversity over the 12-year period of analysis. Average academic rank, tenure, and degree distributions were reported by gender and race categories. For statistical analysis, we used the repeated Escher's ANOVA test to see if any groups were different, and multiple t-tests with the Bonferroni correction to identify which groups differed significantly. So analyzing the gender breakdown of academic positions, we can see at the instructor level or the entry level, there is approximately a 50-50 breakdown between males and females. But as you become more senior in your position, from assistant to associate to a full professor and even chairs, the proportions of females drastically and steadily decline. This is also seen in the tenure track and not on tenure tracks in academic anesthesiology between males and females. And when comparing the degrees, the only real salient degree difference is that there tend to be more males with MD PhDs compared to females. Analyzing the data by race showed that the majority of academic anesthesiologists in the United States were predominantly Caucasian at 67%, followed by Asians at 18%, with Blacks and Hispanic anesthesiologists occupying 4% and 3% respectively. But when comparing the total population to the various leadership positions in academic anesthesiology, we can see that Caucasians disproportionately occupy up to 88, 79, and 72% of the chair, full professor, and associate professor ranks. The proportion of Asian anesthesiologists decreased as academic rank increased. And Hispanic and Black anesthesiologists were also very underrepresented, especially in the full professor rank. A similar track can be seen with tenure, with Caucasian anesthesiologists having significantly more tenure than their total percentage of the population, while Asian, Black, and Hispanic anesthesiologists do suffer in this regard. With regards to academic degrees, Black and Hispanic anesthesiologists were less likely to obtain PhDs or MD PhDs going forward, and this is something that should be noted. So here the data shows a significant skew towards both male and Caucasian anesthesiologists in academic anesthesiology. The data also seems to suggest that while recruitment into introductory positions like instructor is fairly equal, the promotion past those stages into tenure streams or full professorships is not. And this is one place where there can be more improvement to encourage physicians that are focused on improving diversity and productivity in the school towards leadership positions. Once such policies are implemented and the diversity of the population increases, this will be more attractive to other physicians looking to join the faculty, and a net positive change can be conducted going forward, which can hopefully improve both physician and patient well-being for the future. So thank you for coming to our presentations, and we hope you have a great day.
Hello everyone, thank you for taking the time to review my presentation on a research project I completed while finishing my Master's of Education titled Bullying, an Exploration of Nurse-to-Nurse Conflict and the Effects This Has on Patient Care. My name is Camilla. I am a nurse in the St. Catharines Emergency Department as well as Orthopedic Surgical, and I believe that bullying is a pertinent topic that must be discussed within the walls of the hospital. Nurses eat their young is a phrase that has been used for many years within the nursing practice, and one I know all too well. A professor by the name of Judith Meisner coined the phrase nurses eat their young in a 1986 article used to describe the hostility young nurses face at the hands of their more experienced coworkers. 36 years later, and current literature still states that nursing students and new hires are faced with bullying on a daily basis. The most significant and disturbing evidence noted identifying that at least 85% of nurses have been bullied at some point throughout their nursing career. The American Nurses Association defines bullying as repeated, unwanted, harmful actions intended to humiliate, offend, and cause distress in the recipient. Bullying in nursing is a true epidemic. For many years, nurses have had the reputation of eating their young. As such, it is up to today's nurses to change that perspective. It is also up to educators, mentors, and leaders to provide proper role modeling. One can only hope that this topic continues to be researched in an effort to understand bullying as a whole and change the future of nursing. This can be achieved by creating a large group of diverse professionals who are trained in conflict management, which can decrease the prevalence of lateral violence and bullying within the workplace. The social learning theory created by Albert Bandura presents observation and modeling of behaviors, attitudes, and emotional reactions of others. Bandura believed that learning behaviors resulted from direct observation or vicariously through others. When one learns by observation, the learner acquires behaviors without trial and error. Individuals learn with a social situation by observation, imitation, and the modeling of various attitudes, experiences, exhibited behaviors, and consequences of such situations. Qualitative data obtained through a literature review of over 40 articles revealed that bullying is prevalent and can be learned through observation of existing behavior. Through research, the strongest discussion of findings include RPN versus RN role, bullying lives where it is accepted, zero tolerance is beneficial at every organization, reflexivity and reflection performed by the nurse can optimize patient outcomes. A victim of bullying can not only experience physical symptoms, but may also show less productivity, low morale, and absenteeism. And finally, and most important, retention. Many nurses are leaving the profession as a result of bullying. The literature continues to reveal both victims and witnesses of bullying suffer silently and are often confused as to what to do when presented with bullying behavior. This can be prevented by offering strategies, such as the ones presented on the next slide. This slide discusses the findings and suggests strategies drawn from literature for health organizations to prevent or mitigate bullying. The second table lists 6 strategies from various literature for the individual nurse who may be experiencing bullying. How does bullying affect patient care? Several ways, to name a few, increase medical errors, decrease quality of care, negative patient outcomes, impaired performance, disruption of concentration in procedures. The bullied staff are more frequently involved in adverse events for our patients, such as medication errors, falls. And there is a clear reduced level of motivation and commitment to the nurses' work, which shows an increased amount of absence. This final slide is not just for nurses. It's a thank you to everybody at Niagara Health. Thank you for your collaboration over these last very difficult 2 years. We're all in this together. Thank you for listening.
Hello, this is Larry Chambers speaking to talk about how we energize scholarly activity in the Niagara Regional Campus over the last few years. Thank you for giving me the opportunity to present today. So what we have here are some of the types of things that we are up against as a campus, including barriers to enabling students to become involved in research, having less resources than the Tertiary Care Center in Hamilton, and the fact that that the students had the perception that they were disadvantaged by not being in Hamilton and be able to be engaged in projects, and overlooking the opportunities to address important projects and issues in the Niagara region through their involvement. This became even more problematic when we started to look at our particular challenges to Niagara, that with regards to faculty, for example, we only had 7% who had formal research training, and we had 84 students seeking scholarly activity skills and wanting to become more competitive in applications for residency. And the students had this view that locally there wasn't much going on, and they were upset about that. And clinical faculty didn't see themselves as researchers, identifying the need for more faculty development and research. And research supervision was left to only a few faculty. So what we did was to think about this from the point of view of 5 pillars for intervening. One was to engage all the actors, both here and in the Academic Health Science Center in Hamilton, to bring together investments, both small and large, across the community, within the school, within the faculty, and within organizations like Niagara Health. Education of faculty and students, being innovative about that. Setting up a Niagara Regional Campus scholarly activity database where we present the data in a minute that we collect on that, and then celebrating any of our successes. And all this led to achieving our goal, which was to introduce successfully scholarly activity to medical students in a way that they would value for the rest of their medical career. This slide shows that over the previous years there was not much participation until we got this going, and in the first year in 2019, the first year class, we had all of them involved, but not the graduating class. But this increased to 68% for the graduating class in the 2021 year. We had, by 2021, we had 60 active projects and 23 faculty supervising students. So this was a success story from our point of view, and we're doing very well, especially in comparison to the other regional campus, Waterloo, and even Hamilton. So the next steps with this are to introduce an endowed professor in family medicine who has just begun, and also increase, I should say, research opportunities for community-based clinicians. As I mentioned earlier, faculty development is a very important area that we're working on, moving from that 7% for formal training to involving faculty more even if they don't have formal training, in learning on the job, if you want to call that, the see one, do one, teach one. Improved access to healthcare marginalized population, access to healthcare of marginalized population will continue to be our goal, and we have a large network of organizations we're working with on that front. We think that other regional campuses might be able to learn from our approach. And finally, we are leveraging funds and expertise and tracking and supporting ongoing work over the coming years. So thank you very much for giving me the opportunity to speak this afternoon.
Good morning. My name is Corinne Mitches, and I am pleased to present Interventions to Reduce Burnout in the Emergency Department, a systematic review. I am presenting on behalf of the research group. Please note these slides were created by Alicia Lavolée, an NRC medical student. This group declares no conflicts of interest or financial support. This presentation was previously given at the 2021 CAPE and ICEM conferences. As I am presenting from Burlington, Ontario, I would like to acknowledge the lands upon which I present from. Burnout, a syndrome characterized by emotional exhaustion, physical fatigue, and cognitive weariness, is thought to be a byproduct of sustained levels of high stress. The phenomenon of burnout has been associated with loss of meaning in work, feelings of ineffectiveness, irritability, fatigue, cynicism, and the tendency to view people as objects rather than human beings. Maslach defined the three main components of burnout syndrome as high emotional exhaustion, high depersonalization, and low personal accomplishment. Emergency medicine physicians consistently experience the highest prevalence of burnout out of all the medical specialties. Recent systematic reviews quantifying burnout in emergency nurses have also shown moderate levels of emotional exhaustion and high levels of burnout in the domains of depersonalization and personal accomplishment. While this study was completed at the beginning of COVID-19, we appreciate that COVID-19 has made burnout worse in our emergency departments. While there are many reports of burnout amongst healthcare workers, literature examining the utility of interventions on rates of burnout amongst physicians and nurses in the emergency department is scarce. A systematic review was conducted to identify effective interventions to reduce burnout amongst emergency department staff, including physicians, medical residents, and nurses in community hospitals. 4 independent reviewers completed title and abstract screening and full text screening using predefined screening forms. Reasons for exclusion were recorded. Discrepancies between reviewers were resolved by consensus discussion between reviewers. 4 randomized controlled studies and 3 non-randomized pre- and post-intervention studies met eligibility criteria. 3 of the included studies took place in the United States. The rest of the included studies were in Ireland, China, Germany, and Australia. The sample sizes ranged from 21 to 102 participants. 3 studies included emergency medicine nurses, 2 studies included emergency medicine residents, and 1 focused on emergency medicine junior physicians. 1 study followed a multidisciplinary team in emergency medicine. The results of this review showcase that interventions that are effective for one group of staff working in the emergency department may not be effective for others. Among the 7 included studies, there was significant variation in both the duration of the intervention and the interventional approach to mitigate emergency staff burnout. Although the pool of literature was small, it did appear that generally both emergency physicians and nurses benefit from intervention programs that were longer in duration and in programs that address themes of mindfulness, reflective practice, and problem solving. In contrast, residents did not find any benefit in interventions involving group programming that used mindfulness, reflective techniques, and personal problem-solving strategies to foster resiliency. In fact, some interventions, such as reflective mindfulness programming, increased subjective reported burnout levels by adding to their workload and taking away from educational learning time. Among residents, perhaps interventions that are systematic or in the domain of work, education, life balance may better tackle the root of their burnout. Overall, this review of 7 studies revealed a scarcity of experimental research on interventions for emergency department burnout. The limitations with the literature review found impact the breadth of the systematic review's results. Many of the included studies were pre-post intervention studies without a control group, and it cannot be definitively concluded which specific interventions are effective in reducing burnout. The few studies that did examine burnout were heterogeneous in other elements such as burnout domain measures and also participant occupations within the ED, example nurses, residents, or doctors. Thus, a quantitative analysis, meta-analysis could not be done. Moreover, studies were conducted in different countries with varying healthcare system structures that could impact the generalizability of the results. Also, this review does not account for the impacts of COVID-19. However, expanding the implementation and research of interventions targeting burnout in EDs in both community and academic sites may be beneficial to prevent burnout while also providing more data on the effectiveness of such interventions. Furthermore, different interventions that are efficacious for depersonalization and personal accomplishment domains of burnout need to be explored. Interestingly, residents may have very different stressors and drivers of burnout compared to nurses and doctors, and as such require interventions that are tailored to their specific needs. Further, experimental studies are needed to buttress our results. However, this review provides much needed evidence in support of the effectiveness of interventions as a means to combat burnout in ED staff.
Hi everyone. On behalf of my co-author, Dr. Larry Chambers, I would like to thank you for the invitation to present our poster on innovative approaches to learner and faculty interaction in teaching evidence-based medicine. As you all know, we have outstanding academic faculty affiliated with the Niagara Regional Campus, or NRC, but like many other distributed medical campuses, our learners have more barriers to accessing research faculty who have made evidence-based medicine, or EBM, an active part of their career. It should go without saying that distributed campus learners should not be disadvantaged relative to traditional academic centers and should be offered scholarly activity learning opportunities. McMaster's MD education program includes multiple asynchronous recordings of faculty EBM lectures online and 1 3-hour interactive professional competency session with first-year students. In response to this perceived need, NRC's faculty organized EBM primer sessions, which are optional synchronous sessions to learn EBM, giving ample opportunity for learner-faculty interaction. Here we report the content, process, and feedback about our EBM session on what is involved in making an evidence-based decision about a treatment. This is the schedule of the EBM primer series. Our session was delivered on Thursday, February 17th, 2022. The 1-hour session consisted of a 5-minute pre-session questionnaire, a 30-minute presentation of the content. Discussions were encouraged throughout the session. We incorporated 2-minute question pauses to foster engagement. 20 minutes were allocated to learner-faculty interaction, and finally we included 5 minutes at the end for the post-session questionnaire. The session's learning objectives were 1. Apply consort checklist to assess methodological quality of reporting of RCTs. 2. Describe the role of RCTs in the hierarchy of evidence about treatment effectiveness. 3. Describe what makes evidence of treatment effectiveness less certain. And 4. Describe the importance of PICO to determine internal and external validity of trials. The education design principles established by Green and Frankish were used to guide the creation and organization of the session. Preemptive steps were taken to increase attendance for the session, including confirming that the session did not overlap with other events in the MD program calendar, sending out a revised advertising poster which included pictures and bios of the presenters, a list of the learning objectives, and a clinical vignette of a treatment decision-making dilemma. The session was advertised to students through NRC communications. The sign test was used to determine if there were changes in the pre to post questionnaire responses. Only 7 of the 82 students at NRC attended the session. Despite scheduling the evaluation into the session, only 5 of the 7 students completed the post-session questionnaire. When we looked at students' self-rated knowledge about the 4 learning objectives, there was a statistically significant knowledge improvement for the learning objective of apply consort checklist to assess methodological quality of reporting RCTs. The statistical test was based on the 5 students who completed both the pre- and post-session questionnaires. When we asked students about their confidence that each of the 4 learning objectives was achieved, 4 students were confident that the first and third learning objectives were met. 5 students were confident that the second and fourth learning objectives were met. 4 students were likely to tell a friend about other sessions. 4 students were satisfied with the session. All 5 students were likely to participate in future sessions, and 1 student did not like the learner-faculty interactions. All 5 students reported using UpToDate as a summary of evidence. 1 notable comment stated, "I would have liked to have had analyses of high quality versus famous but flawed studies." Pre- and post questionnaire findings revealed that the session was moderately successful. There was a wide variation of perceived skill levels for each of the 4 learning objectives. Due to COVID, the session was held virtually. An in-person session may have yielded different results. Our session was preceded by 4 other EBM primer sessions covering other topics. A total of 15 students, out of the 82 at NRC, attended all of those sessions combined. A recording of the session has been made available to all NRC students. We will assess its uptake. Alternative formats for EBM primer sessions are being explored to create learning formats that meet the learning needs of students and add value to the already demanding MD program curriculum. Future evaluation of EBM learning sessions will use standardized tools such as the Berlin Questionnaire, the Fresno Test, or the ACE test. Thank you again for the opportunity to present this poster, and we invite your comments and questions.
Hi, everybody. I'm here with Dr. Sade Ajayi today and Dr. Shira Brown to talk you through some research that we did in our MBA or executive MBA program at Brown and IE, where our topic was leadership in a time of crisis, important attributes studied and uncovered during the COVID-19 pandemic. So as you all can recall very well, COVID-19 really started to hit at least the US in March of 2020. At this time, I was personally living in New York City, and there was a lot of ambiguity, confusion as to how, as New York City residents, we were going to handle the pandemic as it was spreading really quickly through the city. And at this time, we were also simultaneously getting our MBA together virtually and starting to study topics such as leadership, executive leadership. And personally, I really wanted to understand what makes an effective leader in a time of crisis. And luckily enough for me, I was humbled that both Dr. Brown and Dr. Ajayi really wanted to also understand this topic and do a rigorous research study so that when there is a time of crisis like a pandemic, how should a leader handle it? What are the go-to levers that drive effective leadership? And so this led us to our research question: what are the important leadership practices demonstrated in a time of crisis? And we were able to do this real time throughout the pandemic. So we actually targeted experienced leaders across medicine, business, and politics to really try to uncover in the future, if we were to define, what attributes are needed, what playbook could we really put together so that leaders could turn to it and know what attributes to really study and really practice so that they're prepared for that time of crisis. And I will let Sade get into a little bit more of the details behind the methodology and how we conducted the leadership. So I will pass it over to you, Sade.
Thank you so much, Kendall, and thank you everyone for your time and attention today. So our study design consisted of qualitative research utilizing semi-structured interviews. A literature review was performed that was quite rigorous, which underscored the importance of agile, nimble, and change leadership, as well as emotional leadership and intelligence. Interviews were conducted using the stakeholder identification method described by Schiller et al. In 2013. 4 stakeholder groups were identified with a vested interest in important aspects of the COVID-19 pandemic. And they are as follows: policymakers and governments, clinicians and professionals, health and social services providers, and private businesses. Using this framework, 19 stakeholder interviews were conducted in total, and the subject roles were as follows. There were 6 chief executive officers of hospitals that were interviewed, chiefs of hospital services, including infectious disease and critical care, 4 senior government officials, including 3 United States representatives and a former Prime Minister of Australia, and 3 mid-level physician leaders, including 2 vice presidents of outpatient medical services and 1 vice president of business quality and supply chains of a multi-billion-dollar private enterprise. Interview questions were semi-structured interviews where a guide was curated and employed using an established framework, which was originally described by Kaleo in 2016. And that framework was titled Leader Behavioral Description Questionnaire. From this, we were able to determine dimensions and subdimensions, and coding ensued using ethnographic research methods. Next slide, please, Kendall. Here you can see our results. You can see that 3 strong categories of leadership qualities emerged, including emotional intelligence, in which we had 7 subdimensions, strategic thinking, in which we had 4 subdimensions, and communication and transparency. Next slide, please. Although we are very excited that we have uncovered 3 main dimensions, we felt that it was also important in our research to provide more concrete information to readers on our thoughts behind these dimensions, and that's why we included the subdimensions in our results. These learnings are consistent with some of the learnings that we did gather and garner from our MBA experience, in particular, the leading people, teams, and organization class in which we were grateful to participate in. Mostly subjects on change leadership and nimble leadership, as well as emotional intelligence, were again underscored. We feel as though this research, which we hope will add to the current body of evidence and literature on crisis leadership, will help leaders form a playbook for many leaders to turn to when they are in crisis, as we realize that COVID-19 unmasked many of the difficulties that leaders might have in a time of crisis, and they'll be able to turn to this playbook again and again when other crises emerge. We hope that this will also be a springboard for personal development in leaders towards a journey that may be fruitful in hard times for both them and the people that they employ and are leading. Thank you so much for your time and attention. And on behalf of Kendall and Shira and myself, we hope that you have a great day.
Thank you.